The ablation procedure is really basically pretty straightforward. A patient comes into the hospital, receives an IV, and then gets a light anesthetic so that they're asleep, basically not aware of what's going on. And then we access the femoral vein in the groin region, much like a conventional heart catheterization procedure. It's a small puncture hole, doesn't involve any stitches. And through that we thread a series of plastic tubes from the groin up into the heart and access the area where most of the atrial fibrillation comes from. And that's the junction where the blood vessels which return blood from the lungs to the heart connect to the heart, something called the pulmonary veins. There are typically 4 of them, and they live on the back side of the left upper part of the heart.
Once we have catheters in the left atrium, we can then measure electrical signals coming from all the pulmonary veins, which are our targets, and then we bring the cryo balloon catheter up into the left atrium in a deflated state. We will then position it near the pulmonary vein we're targeting and then inflate the balloon and gently apply pressure against the balloon at the opening of the pulmonary vein. This occludes blood flow temporarily and allows us to deliver the cryo energy to create pulmonary vein isolation. After about a 4-minute energy application, the balloon is then deflated and removed away from the pulmonary vein opening, and we can then go back and measure with our electrical catheters whether we've achieved the isolation we want or whether we need to go and do additional energy applications.
The fundamental difference between conventional radiofrequency ablation, which is the technique that we've been doing for essentially the past 10 years for atrial fibrillation, and cryoballoon is very easy to understand. In the radiofrequency approach, we do a point-by-point ablation. So if the goal is to isolate one of these pulmonary veins, we have to take a catheter and move it, and at each individual dot destroy a particular area of tissue, and do that in a what's called circumferential manner around the mouth of the vein. That requires a greater degree of skill and time and patience in terms of moving the catheter, because remember, the heart's beating and moving the whole time that you're doing that, and you're trying to synchronize the zaps so that you get exactly the right area. The beauty to the balloon is that we're taking it and sealing that whole area, and with one application we're creating a nice circumferential lesion, which is a destruction of tissue by the freezing approach, all the way around where that balloon comes in contact. Not all of the blood vessels are perfectly round, and it does require some unique skill in terms of manipulating and recognizing the way the balloon fits into that location. The risks and complications with this procedure are the same in terms of the types of problems that may occur with any of the other techniques for ablation that we've been doing over the past couple of decades. Anytime you access a blood vessel, there's always the risks of puncturing, bleeding, blood clots. We're using anesthesia, so you could have some sort of a drug reaction. Inside the heart, when you're working, there's a risk of a blood clot that could cause a heart attack or a stroke. There's the chance of puncturing a hole in the heart, which could cause bleeding that might require surgery to repair that. Fortunately, these are very rare occurrences.
The other potential risk with a cryoballoon ablation is damage to the phrenic nerve. This is the nerve which comes from the brain down to the diaphragm and helps control breathing. This can be damaged with a cryoballoon energy delivery, and currently during the procedures we test this nerve during the energy delivery so that we can stop it at the first sign that there's any injury. Following the procedure, most patients will spend the night in the hospital. Typically, they'll be discharged the next day. There are very few side effects related to the procedure. The most common area of discomfort would be some mild discomfort at the site where we get access with our catheters in the groin area. Few patients may have a little bit of chest discomfort, but other than that, most are fairly symptom-free.
They lifted the anesthesia, and I came out of it. And my initial reaction was, wow, this is just as smooth as it can be. And it was that way from then on.
Some patients may still experience several episodes of atrial fibrillation as the ablation sites are healing, but these should go away within a month or so after the procedure.
We had an expectation given to me by the doctors that said that the heart is trained to AFib and that it is not unusual and is even expected for it to happen perhaps one or more times after the surgery. In my case, I had one episode that lasted about 3 or 4 hours. And after that, there was no more AFib.
For the next week or so, we want them to try to avoid excessive physical activity to allow the sites where we've gained access in the leg to heal up properly. Most will also be on blood thinners for at least a month or so after the procedure.
Right after the surgery, there was a need to go on Coumadin, and that was both a precaution from the surgery itself, as well as just any AFib that might occur, keep the blood thin and prevent the clots and so forth, the complications that go with that. So that was continued for several months after the surgery, but I did not have to take any AFib medicine at all. After a period of time, stopped the Coumadin, and I've not had to take anything since then. As far as coming out of the surgery and finding this smoothly beating heart, I like to liken it to an old Chevy 350cc V8. This heart had been given a new distributor cap, new points, new cables, and new spark plugs with platinum tips. This thing hummed. It just did super. It just ran beautifully.
I honestly can tell you I feel better than I've ever felt in my life. And I'll tell you a thing that I didn't really appreciate is that I thought I was better at a month and 2 months after the procedure. But when I got off my medications, and there was something about getting off my medications that made it better. But there was something else about, I think that when you're in and out of AFib, I'm firmly convinced that it's a more metabolic demand. It's your heart's not functioning efficiently, so you're more tired than you really think you are. I thought I was back to normal at a certain point, but once I got off all the medications and I was out of my AFib for a month or two, all of a sudden I went, oh yeah, this is how I used to feel. And I'd lost that.
Well, I was thrilled when I realized that the problem would be solved, that it was successful.
Yeah, I can tell you right now I'm in better shape than I've ever been in my life.
I was so happy for him because I think he was, we so look forward to the years ahead, especially since we're empty nesters and, all these things we're going to do. And I think before the procedure, he thought, was wondering if he was going to be able to do the things he wanted to do. Can I play golf? Can I still go hunting? And can we travel? And so it was like a whole new lease on life. Like, I've got my life back and I can do those things now. So it was very emotional, we were very happy.
And there's a lot of people, they think it's an old person's disease, and at 55 I don't think I'm that old and I'm still doing a lot of stuff. And I want to tell people, make sure, you can be scared, but make sure you're scared for the right reasons. You got to realize that AFib is something that's going to continue and get worse. There is a way to treat it. Not everybody gets a great result like me, but most people get a really good result. And if you don't do anything, it's only going to get worse. And I think there's a very safe way to do it now, and you ought to at least look into it rather than just sit back and accept your fate. I'm so glad I didn't.